Hey there, everybody. Jay Harness. It's a real pleasure to be with you as a founding member of BSI. I'm just sorry that I'm not there with you in person. I hope it's been, as usual, really a spectacular meeting. So let's get going with my talk presented to you through this video. Well, we're all certainly aware of what a big issue cancer is globally. One out of every six deaths worldwide is from cancer. It's estimated that globally cancer cases go up by about 70% over the next two decades. So this talk on exercise oncology, I think, is really relevant. It is a global phenomenon. And joining me today are Katie Schmitz and Karen Wonders, who have contributed to this presentation. My only disclosure is I'm the Chief Medical Officer at Maple Tree Cancer Alliance in Dayton, Ohio. We are a nonprofit provider of certified oncology exercise specialists in the US, and I'll talk later about the programs that we export internationally to help folks set up their own exercise oncology programs globally. Well, what the heck is exercise oncology? It was not a term that I was familiar with until a few years ago. I think a good description of it is adjunctive therapeutic approach to cancer patients emerging from over 2,600 prospective clinical trials conducted over the last 25 years. These clinical trials have resulted in moderate to strong evidence of the positive impact of exercise on cancer patients, their fatigue, their anxiety, their depression, their quality of life, their physical function, sleep, bone health, cancer-related lymphedema. It's important to remember that these are evidence-based programs of supervised, individualized exercise training done on site in medical centers or out in the community or virtually. The goal of all of us in this world internationally is to make exercise oncology programs a standard of adjunctive care, as it already is in Australia. For those of you in the room from Australia, you're about 6 years or more ahead of everybody. The American College of Sports Medicine has been a big leader in this world, and they have started Exercise is Medicine. Imagine if exercise could be a pill, how many each of us would be taking regularly. Here's just a graphic representation of all these clinical trials starting back in 1900. They have accumulated a massive amount of data and information. And then when you look at not only 2,600 clinical trials, but several thousand publications, if you then look at the summary of evidence in breast cancer survivorship from all these clinical trials, and patients who post-diagnosis were physically active, and I'll talk about what that means in a few minutes, and if they were and maintained physical activity not only during treatment but afterwards, there's a 31% reduced risk of cancer-specific mortality, a 22% reduced risk of cancer recurrence, and here's the biggie, a 41% reduced risk of all-cause mortality, meaning dying from things other than breast cancer. And what are the exercise guidelines during breast cancer treatment? And these guidelines are pretty much the same globally when it comes to long-term survivorship as well. But during active treatment, we're trying to improve symptoms and side effects. And it is recommended that breast cancer patients perform aerobic exercise for 30 minutes a session, 3 to 5 times a week, which means walking briskly, for crying out loud, get your heart rate up around 100, and 2 to 3 times a week of some resistance training, which can be done at home, in a gym, or at a fitness center, in the medical center, or wherever it can be done. And speaking of what are the locations for exercise oncology programs, there's fundamentally two ways of thinking of this. The first, in an initial way, at the time of diagnosis, is at the medical center level, which can include prehab programs, and we'll talk more about that in a minute, active treatment, during active treatment, and immediately post-treatment. And then just as important is in long-term survivorship for years after completing treatment, which can be done out in fitness centers in the community, other types of community centers, or beautifully within fitness groups. And I'll talk more about that in a minute as well. If we look at the components in a medical center of what an exercise oncology program is, it involves pre-screening, meaning that the physicians have referred the patients to the program and given approval for the patients to participate. The exercise specialist would do a fitness assessment. Less than 20% of Americans exercise regularly, and they have all sorts of different levels of fitness when they show up with their diagnosis of cancer. Then creating a specific exercise prescription, getting the program going, and then doing the reevaluations generally around every 12 weeks. At Maple Tree, this is the components of what these programs look like within medical centers. Phase 0 is the prehab, particularly relevant in breast cancer with all the triple negative and HER2 new positive patients we see that we know are going to get neoadjuvant chemotherapy, get them going with exercising before they ever even get their port in or get going with their treatment. Otherwise, phase 1 is during chemotherapy or radiation therapy. Phase 2 is they've completed chemotherapy and radiation therapy, or they may have only received surgery or hormonal therapy. And then phase 3 is generally done outside the medical center, out in the community and long-term survivorship. So what are the impacts of these exercise oncology programs? Here's some data from the Maple Tree Cancer Alliance database that we published a few years ago on 11,248 patients. What's the physical and psychological impact? Well, increase in quality of life of nearly 60%, increase in cardiovascular endurance of 15%, muscle endurance around 18%, nearly 32% in flexibility, feeling more positive, 76% roughly, and feelings of support, particularly from their trainer and or other members if they're in a group, of nearly 60%. So the impact physically and psychologically on patients is quite measurable and real. What about the financial impact? Well, and this is again from prospective studies at Maple Tree institutions, decrease in inpatient hospital stays of about 6%, hospital length of stays around almost 20%, ER visits 27%, total patient encounters of 33%, and readmissions of 47%. So you can see, excuse me, that the impact is really quite real. Well, what are the different models for how to do exercise oncology programs? There are fundamentally three. One is called the group fitness model, and often these are done out in the community, often during long-term survivorship, such as Live Strong at YMCAs around the United States, Dragon Boat racing groups, both in the United States and internationally, an organization like Fit Steps for Life. And what are these groups? These are group fitness classes specifically for cancer patients and survivors offered, here's what's really important, by professionals with specialty training in exercise oncology. So that's one model. Another model is called the consultation model, which would be having a person embedded in a cancer clinic or hospital where they go through the electronic medical records where the referrals are made to an exercise oncology specialist. Again, they do an assessment, create a prescription, come up with a minimally guided program, referral out to a community resource, or even having the patients do it at home if they're able to do that. Or, and really importantly, appropriate triage of physical medicine and rehabilitation or physical therapy is needed. I think it's really important to realize that physical therapists are generally not trained in cancer rehab. In the United States, less than 10% of physical therapists are involved in cancer rehab. And so the exercise specialists can work with physical therapists or in parallel with them. The third model is the one I'm involved with at Maple Tree at 65 locations in the US. which is a one-on-one model. It's very, very similar to cardiac rehab models, a one-on-one assessment and personal training during and after treatment. I've already outlined what those phases are. And here is these specialists are embedded within the cancer center or offered as a virtual one-on-one telehealth program. Since COVID, we're more and more involved with offering telehealth programs, and patients can do quite well with them. Within cancer centers, we can be in departments of physical therapy using their equipment in a small gymnasium that a cancer center may have or other locations within the center. Well, let's switch gears now as we try and wrap up and talk about Mapletree's effort at international exportable exercise oncology programs. As I said at the beginning of this talk, this is really a very important international effort. What's going on globally is the creation of a Society of Exercise Oncology. We had an initial meeting in Boston a few months ago. We had representatives from around the world. So this is really a global effort, and Mapletree can export exercise oncology training programs. So what do these partnership opportunities look like? Mapletree collaborates internationally to provide education, training, and certification of professionals to conduct and manage their own cancer rehabilitation or exercise oncology programs. These programs involve three specific areas: training and certification of the people setting up the programs, cooperation to coordinate and assist in developing the cancer rehab programs, exercise programs in partner countries, and then establish the programs to exchange information and to promote exercise prescription programs specifically related to cancer rehab. Also, once the programs are set up in a specific country, like one we have in Australia, the folks in Australia then can start to reach out with our materials and start setting up other programs within, as an example, Australia, through the people that we've trained, and then and expanding in intra-country as well. So the Mapletree programs are two courses. One is called an Exercise Oncology Instructor, or shorthand is an EOI. These are trainers who can then operate the exercise portion of the cancer rehab program. Here's sort of a typical setup in a medical center where you've got upper level management, the exercise oncology educator that I'll talk about in a minute ago, and then the line folks, which are the EOIs, the exercise oncology instructors. The next level, at this level, is the exercise oncology educators. These are individuals who can then teach others how to prescribe exercise in their cancer rehab programs and expand the number of programs in country by setting up other programs under their leadership, let alone their own. These courses each take around 40 hours. The EOI course is online, and the EOE is done in person, either in the United States or, as we did recently, we had 12 countries coming to Ohio, where we educated more of their folks, where we already had EOIs to set up the EOEs and then give them the horsepower they need to be able to then potentially expand intra-country. And speaking of how big the Mapletree international family is, I've already mentioned Australia, Brazil, Chile, China, Greece, India, Italy, Japan, Mexico, New Zealand, Paraguay, Poland, Portugal, Serbia, South Africa, South Korea, and United Arab Emirates. Well, I tried to get through all that as timely as possible, knowing I only had 18 minutes. The first version of this talk, I was way over my time. So let me thank you for the privilege of your time to talk briefly as I could about Exercise Oncology, which is clearly a global phenomenon. Thank you for your time. Let me just share with you that I have, about almost 2 years ago, created an Exercise Oncology email list that now has 270 members in 18 countries. What I try and do weekly or 2 to 3 times a month is to send to each of the members a PDF of the latest publication that I can find on the impact of exercise on cancer patients. And these are not just breast cancer patients, but all cancer patients. If you'd like to be added to this list, I'd be privileged to do that. Simply email me at jkharness@gmail.com. Give me your information, obviously your name and email address and what you do, and I will add you to the list. Also coming hopefully in the next 6 weeks or so is a new website that I have built but have not gone public with, called Cancer Fitness. The idea of this website is an educational site, again, to have the latest and greatest information and science about the impact of exercise on cancer patients for both patients as well as all of our colleagues. The site is built but not public. If you want to take a look at it, it's at www.cancerfitness.org. Well, by golly, as I wrap up here, and I think I'm in a much better time frame than I was with the first version of this talk, which was about 9 minutes over time. Again, I want to repeat what a privilege it is to be with everybody. I know this is the last day of the BSI meeting, one of the last sessions, so hopefully this has gotten to some of you there. Hopefully you've had a spectacular time. We have such a great organization at Breast Surgery International, and I want to take this opportunity to wish you all the best and to have very safe travels back home. Bless you all. Thank you very, very much. Take care. Bye-bye.